Hello, everybody. This is Irma Jennings from Food for Healthy Bones, and I'm very happy to be joined again with Dr. McCormick. Dr. McCormick is a colleague of mine. We met in, I don't know, 2000 and I want to say 18 or so, I'm not sure, through another bones trier who I spoke about earlier, who brought your book to my attention. Then we all dove into the book, and then we did a book club reading, and then you came and you talked. So let me just make sure we have, everybody's muted. Okay. So I am the originator of the Bones Tribe and Food for Healthy Bones. And what I do in the Bones Tribe, my focus is food, and then I branch out from there. Everything happens with the shovel, with the fork that we put in the mouth. So once a week in the Bones Tribe, Vicky and I come up with recipes, bone-loving recipes that are really unique. And we have all the nutrition content and things of that nature. So that's what I do. And then I refer my clients out to Dr. McCormick and to others, depending on location, depending on needs and things of that nature. So I started out with osteopenia, diagnosis of osteopenia in my 50s, and I was told, you're going to go downhill fast and you better take this Fosamax. And I declined. And I'm in my 70s, and my bones are still osteopenic, my spine and my hips. So Dr. McCormick, do you want to tell a little bit about yourself and your history? I know there's so much to say.
I found out I had osteoporosis at age 45, had a lot of hip problems with that. First bone density I had was negative 4.3 spine, and then what got a little bit worse at negative 4.5. My hips weren't as bad. They were, I can't remember, maybe 2.7, 2.8, something like that. Like you, they wanted to put me on different things, and I said no. And but then I just started to fracture a lot, and so I did go on Forteo and then a short course of Fosamax, and that kind of pulled me out of the hole. And that was 20-something years ago, and then I'm just staying right where I was after I got a hole. So I haven't lost since then. So for 20 years, I haven't lost anything, and I'm not on any drugs. So, but like you, I think what's really important about that story and your story is, you were told you're going to get worse, and I did get worse, and you were able to stop yours. I wasn't at the beginning, but then I was at a much worse point by then, and I was fracturing a lot. I had to. I didn't have a choice. But then you get pulled out of the hole, and then you stay there. And that's what's the magic about doing what you do, and helping people to either get out of the hole or stay out of the hole or something like that. But I think what people don't realize, because their doctors, their medical doctors say, yeah, you got to be on these drugs forever. And that's not true. The drugs are necessary sometimes. They're not necessary at other times. But usually, if you have really bad bone density like mine, you can take them short term and then stay out of the hole without the drugs. So that's the important thing about that story.
That's an important piece, because it feels like a long-term investment in the pharmaceutical industry when you start on the bone medication. And it's not necessarily true. And that's what opens up the conversation to bone markers. But before we get there, how many fractures did you have?
Well, I had, I think, just 12 or 15 in those 5 years after I had osteoporosis. But over my life, I've had 22.
22. I think I know the answer to this, but just remind me, did you find out what your root cause was?
No, I mean, I think like everybody, it's not one thing. I mean, I'm gluten sensitive. I'm not celiac. I had, growing up, I sure didn't eat as well as everybody else. I have no idea what my bone density was when I was 15 and 20 and 25 and 30 and 40. I have no idea. So it wasn't probably just the gluten. I train hard, as you know. I do a lot of sports, and I work really hard in that. So that increases pro-inflammatory cytokines. But it's a combination of things. So Yeah, it's not just the gluten for me. It was overtraining and probably not eating well. So
Yeah, so that gets into that whole thing about, well, I'll just do my vibration plate, or I'll just do yoga, or I'll just do this. And it's a whole picture. It's the whole body, and the approach has to be through a whole mindset.
that's where these bone resorption markers help. And all lab markers help, because it isn't just one thing. You have to not just do one thing to fix it, and you have to do not just one thing to figure out what to do to fix it.
Right, right. So the resistance that so many of my clients have, and perhaps your patients have, is that the doctors don't want to order the bone markers. And why do you think that is? The pushback that I get is that they're unreliable, that they're unpredictable. And
I can totally agree with that. And I think that is such an important thing to talk about. And to tell you the truth, I just wrote a new book, as you know, and in that book, I don't really go into this, what I'm just going to say right now, which I should have, but I think that, because I just thought about it earlier today, but I think the reason why there's so much pushback is because of the variance of these markers.
right.
And that's why at the beginning of your thing you just did with listing all these markers, you said so correctly, you have to do these right. You have to do them fasting. You can't take collagen. You can't take biotin. When you're doing a urine calcium, you can't take supplemental calcium for 48 hours before and during the collection. All these markers are so sensitive. You have to have the patient do them just right. And if a person, if like on the C-Telopeptide, if you don't do that lab draw first thing in the morning, it's going to be wrong. So if you wake up at, it's 6:30 and you drive to the lab and you get your marker done at 7:30, that's great. But if you wait until 9:30 or 10, it's not going to be accurate. Like, for example, C-Telopeptide is at its highest at maybe 2 or 3 in the morning when you're still asleep. And then it starts going lower and lower and lower. By 2 or 3 in the afternoon, it's at its lowest. So if you wait, I went to, did I tell you this? I was at the doctor the other day, about 2 months ago, for something else. And she so nicely said, "Hey, Keith, you want to do any other labs?" Which I've never had an MD ask me that before, but it was quite interesting. She said, "Do you need any other labs, son?" I go, "Sure." So this is 11:30 in the morning. Sure, throw in a CTX in there. So I had eaten breakfast. It was 11:30. My CTX is always at around 380, 400. That's what it is. So it's a little too high, but it's not terrible, but it's always at 380 or 400. It came back at 99. So, and I go, whoa, that's great, but it wasn't accurate. It was 11:30. I'd eaten breakfast.
Right. So this is a really important point as far as the timing, and that's what the PDF that we have. Can you see this? I'm just showing that it's in the chat room to open it up. Really is very, very detailed on when to get the test, fasting, timing, things of that nature. So it's not as overwhelming as it may appear, but it's very, very important to understand when. And if you go to LabCorp or if you go to Quest, they're going to have different references, correct?
Yes, but that is why doctors don't use them, because they see how variable they are, and they don't push their patients. They don't understand that they need to push their patients to do these exactly right. They don't take the time to say no biotin, no collagen, do it first thing in the morning. And so therefore they're all over the map. But if you do it right, then they're helpful. If you do it wrong, it's very unhelpful. And
yeah, so, and that's a point that can't be made enough. I like to track things because that's my personality, and some people are that way. Do you ever track your information, or you just write it on a sticky note and like you do with the TBS?
I could be a salesperson for sticky notes.
All right, so you do the sticky note thing. Vicki, can you share that the chart that we created? Just going to show you something. So this is one of the charts that we created, And it shows the, we're going to talk about some of these tests, the bone specific alkalinephosphatase and what that is. And these names might be foreign to you, but you put the lab in here, and then you put the Q or an L, or if it's an other, put a 0 or other, the date, the results, and the reference range of that particular lab that you're using. And I think that when you go to a bone doctor, like Dr. McCormick, he'll look at this and say, okay, now I can really draw some sort of conclusion on this. Does that make sense, Dr. McCormick?
Yeah, it's great. It's a great tool.
So can you take that off the screen, Vic? Okay. All right, so should we dive in now? So I just wanted to go back to the chat. People have said that they're familiar, they're not familiar. Let me just ask and just put a yes if you can open up that PDF that I have in the chat room, or if you opened it up prior. So if you could just do that, that'd be really swell. Okay. Already got it. Okay. Okay. Cool. Well, everybody's doing okay. All right. So where do you want to go? So when you're going to talk about the CTX and you're going to give the proper term for it, the proper identifier, why don't we start with that one? Because that's one of your favorites, right? The CTX.
It is. And it's very confusing when you're talking about terms, because there's like, it's referred to in 6 different names. So it can be C-Telopeptide, it can be collagen type 1 telopeptide, it can be called beta-lapse telopeptide, it can be called cross-lapse. There's lots of different names for it, and that's confusing to people. But it's all the same thing. So when your doctor orders it, typically it's just called C-Telopeptide or CTX.
Okay. So I just want to reiterate this point. The point of this meeting today is to educate and to take some of the mystery out of, like, oh, do I wait between Dexas? What do I do? I just have to wait here and get my Dexa and say, oh gosh, it didn't work. Well, what didn't work? So that's one of the reasons why we want to dive into the bone markers, to see what's out of whack. So, okay, the CTX, why do you like that so much?
Well, not only out of whack, but to make sure that what you're doing is working. Right. So for example, for a medication, if you take a bisphosphonate, well, you want to get a baseline C-Telopeptide, and 3 months into the anti-resorptive medication, the bisphosphonate or Prolia or whatever you're taking, then you need to do it again. You need to do a repeat. 5% of the time these drugs don't work. So it'd be silly to take this for 2 years and think you're going to get another bone density in 2 years, and then, I had this one patient and she was on Forteo, and they didn't do pre-treatment, and then 3 months into treatment to see if actually for that medication you do P1NP, but they didn't do that. And at the end of 2 years, her bone density was actually just worse. And the reason why is because it didn't work. So she injected herself for 2 years, didn't work. Please don't do that.
Please don't do that.
Test beforehand, test afterwards, and when you're doing even just nutritional things. The reason why you do these labs is not only to see what's the best thing to do, but also to see if what you're doing is working. If it's not working, you move on and do something else.
So this is a voice, and you can have a voice and say, hey doc, this is not working. Let's examine. And there are many people that I have seen, and just as you were reporting, Dr. McCormick, that try medication, it doesn't work, and then they go to another medication, and then they go to another medication. So it's looking for the right medication. If you're going down the medication route, we're not there at that point. I'm not there. Dr. McCormick was, but this is the information that you will have if in fact you decide to do that. But even if you don't, even if you're not at that point, to keep track of your bone markers.
And it also matters if you are to a point of a medication, it matters which medication. So I don't understand how any doctor could prescribe a medication without doing bone markers. For example, if you have a negative 3.4 spine, at negative 3.2 spine, something like that. So you're kind of on the borderline whether this should definitely be a medication treated issue or not, but you're just on that borderline, and your C-Telopeptide comes back at 280. 250 is a good idea to do a bisphosphonate? Probably not, because it's not going to do that much good. If it
Hmm.
comes to 500 or 600, yeah, if we can't get it down nutritionally, then that's appropriate thing to use an anti-resorptive for. But you don't use it for low bone turnover osteoporosis.
So somebody is asking in the chat, and Sandy was kind enough to put a comment in there. Can you explain what a bone marker is? So let's put that in layman's term.
A bone turnover marker, there's two kinds of bone turnover markers. There's a bone resorption marker and a bone formation marker. Bone turnover is just how much activity is going on within that bone, how much bone remodeling is going on. Bone remodeling is a combination of formation by the osteoblasts, by destruction of the bone by the osteoclast, and then the osteoblasts come in and form bone. So we want to see how much activity the osteoclasts are doing, so how much breakdown of C-Telopeptide, how much breakdown of collagen, how much breakdown of bone there is, and then that releases the C-Telopeptide into the blood, and then we measure it. So it's a measure of osteoclastic activity. Then the osteoblasts come in, form the bone. So we want to know, hey, does this person have bone loss because they just have high osteoclastic, or are their osteoblasts kind of sleepy and tired and not doing their job? Because osteoblastic activity increase will increase the P1NP and osteocalcin. So the bone turnover markers are just a way to look at not only activity of the bone cells, but your fracture risk. And that's the most important thing that they do, because some people can have a 400 CTX and some people can have an 800 CTX. And are they losing bone or not? Not quite sure, but sure, if they have an 800, their fracture risk is way higher than somebody with a 400 CTX.
So going back to a point which I don't think we can drive home enough, before you go on medication, if that's the route you're taking, you should absolutely have a baseline of the CTX and the P1NP, or just the CTX?
If you're going to, if you
Depends on what drug, right?
phosphonate, just the CTX.
Mhm.
If you're going to do Forteo, Timelos, or romosozumab, the Avidity,
Mhm.
P1NP for sure.
But not both. If you're doing
Then you do both. Yeah, then I do both.
the anabolics. So,
You don't need P1NP or bone-specific alkalinephosphatase or even osteocalcin if you're just going to do a bisphosphonate. This is CTX or an NTX if your doctor, NTX is, which is another form of what we're talking about here. We'll get into it later, I'm sure. But NTX, some doctors like the serum NTX. I used to use the urine NTX, but it's not as accurate, so I don't use that anymore. But some doctors still use it, which they shouldn't. But a serum NTX or a blood serum CTX is the way you should go.
so what Dr. McCormick is saying is that basically it's a blood test for both the CTX and the NTX, where urine was originally, it's not as effective or as good, keeping it simple. Okay, so I just want to think about the choice. Let me go back for a second. So one of the things about the Dexa is that we take a Dexa test way too late in life. You agree?
I agree.
And as far as you're concerned, when should somebody take their first Dexa test?
For even at the most expensive, it's $600, but probably get it at $300 or $200. It's just such a great insurance policy. So, 45. I wish I would have had mine at 45, 40, 45, 50 at the latest,
Mhm.
not 60,
Yeah. So there's that whole insurance and Medicare and how often you can get it, how often you can be reimbursed. And to Dr. McCormick's point, the cost of it, yes, it's an insurance policy. And I have worked with clients and called radiologies or where they do the Dexa and said, listen, I'm calling for a non-insured patient. What's the fee? And they gave me a very cheap price. So this is within our ability to negotiate. We could negotiate like with the big companies that negotiate with Medicare, right? But we're an individual. We could just ask the question. And if they say, no, we don't do that, you can maybe move to another radiology, or university is better because that's when you get your trabecular bone score. So the Dexa with the trabecular bone score. So just tuck that away. We're talking about an investment in your bones and in your health and in your life. and it could be out of pocket, but you could manage that in some way. I spend a lot of money out of pocket for my health. That's my insurance for me because I'm worth it.
And a fracture is going to cost you a lot more.
The doctor's going to cost you a lot more?
Fracture is going to cost you a lot more.
Oh, yeah. Oh, yeah. Okay. Joy, yes, this will be recorded, and anybody that has been on the call or has registered will receive the recording. So this is all good. And it's necessary to go through a couple of times and get the language down and really understand. Okay. So we talked about the CTX for the bisphosphonates. We talked about the P1NP for the other family of drugs, which is when would somebody do that? When would somebody do the anabolics in your mind?
If they have low TBS, a low trabecular bone score, and or a low bone density. So, when you start getting to a negative 3.5, 3.6, 3.7, maybe 3.8, that's when I start thinking, okay, if it's a negative 4, negative 4.1, 4.2, anything like that, you definitely have to do an anabolic. I don't think an anti-resorptive is good enough because you're just plastering on some density onto a crappy foundation. So you need to remodel that foundation, get some new quality bone there, and then that's what's going to take you forward, and you don't have to worry about it as much. But if you're taking a base that's a negative 4.0, which remember, the bone density is only bone quantity, it's not measuring bone quality. And so if it's a low bone quantity and quality, you got to do an anti-resorptive. And speaking of which, if a person's, let's say, at a negative 3.2, negative 3.3, we don't know, what's the best thing to do? Get a TBS. If that TBS comes back, great, because maybe they're a 5'1", 110-pound woman where the bone density looks worse than it really is in smaller women. And so we get a TBS and our TBS looks great, probably no reason to do an anabolic.
Okay, so let's just break that down. So TBS is trabecular bone score, as Dr. McCormick said. Some facilities, usually universities, have you found that other facilities have the TBS? Usually,
not very many. In Massachusetts, we have 10 of them. That's it.
So trabecular bone score measures, this is very simple terms, the inner working of the bone, the lattice of the bone, right. And the Dexa measures the outside.
It's not another test, it's just a computer add-on to the bone density itself. Right. You don't have to do anything else, than just your bone density, and then they have the computer program then to analyze that bone density and give you a TBS score.
So that's an option that is highly recommended. I do mine at University of Pennsylvania because they have the TBS, and I want to know everything about my bones. So again, you're on the table, you don't feel anything. You don't even know that you're having the TBS done. Do you recommend people getting the forearm done?
I do, and the reason, but most places don't have that capability for some reason. But yes, and one of the reasons why I love having forearm is because the anabolics, the Forteo and Timelos, sometimes degrade forearm scores. So if you have a negative 4 forearm, then you might want to be a little bit cautious about doing something like Timelos.
Whoa. Okay, that's new information. Okay.
Not always, but
right.
Parathyroid hormone affects cortical bone more than trabecular bone. That's why a lot of people who have primary hyperparathyroidism have low forearm bone densities, because that's what the parathormone attacks mostly, is the cortical bone, more so than trabecular. And Timelos especially fits into the parathyroid hormone receptor a little tighter, a little better than the Forteo drug does. And because of that, that's why you get 9 to 10% a year for the first year of bone density improvement for Timelos, and you only get 8 or 9% of improvement for Forteo. But because the Timelos works so well, like I said, it fits in that parathyroid hormone receptor even better. So that means that it may degrade the cortical bone of the forearm. I've had 3 patients in the last 2 years where their bone density in the forearm with Timelos went from negative 2.0, which wasn't bad, to negative 4.0.
What? Okay. Okay. So
you got to be a little careful, but that's why I'm saying, and that's why it's also important to get a bone density at the year mark with an anabolic, not wait to 2 years. Let's see what's going on, and let's see what's going on in the forearm.
right. So get a DEXA. Uh-oh, now my sound is going. So get the DEXA and get the bone markers. I want to say that when you're getting your DEXA tests and you're adding the trabecular bone score, it is, every place is different. This is the unfortunate thing about this business, the world of bone health, is that it's not everyone's doing the same. So you will need a script from your doctor.
And the script needs to say TBS on it.
It needs to say TBS, and it also needs to add forearm. I don't know that there's a script for the forearm, but my script just says add forearm.
But a lot of places don't have it, and then a lot of places don't have TBS, so that part of the script will go unheeded, but that's just the way it goes.
Right, and the other problem is when you call the facility and you ask them if they have a trabecular bone score, you'll probably get Nurse Ratchet, who's the gatekeeper at the front, who has no idea what you're talking about.
But that's why when you call radiology. You call the hospital, you say radiology, please. And then when the radiology department comes up, then you can say, do you have Dexa with TBS capability?
Right. That's a really good point, because people get shied away and they're like, nope, they don't have it. The other problem that I have found with my clients is that nobody can get, it's very difficult to get printouts. I know you don't do CDs. Do you have any kind of a, well, that's a whole different conversation. We'll do that another time, but that's another question. Okay. So we got a little bit into the bone meds because that's an important piece for the bone markers. So do you want to talk about the bone specific alkaline phosphatase?
I don't use it a lot, except to if a person has a high phosphorus, and if a person, when I'm trying to make sure. So alkaline phosphatase is produced not just by bones, but it's produced by the liver, by kidneys, by the intestines. So you kind of have to know why a person's alkaline phosphatase is increased. And so for that reason, you do what's called a bone-specific alkaline phosphatase. And that will tell us whether is that alkaline phosphatase increased because of the bones or not. Oh. And if it is, then we know that they have high bone turnover. But the reason why to use BSAP when you're monitoring somebody with osteoporosis is if they have, if they're on a bone and on an anti-resorptive like bisphosphonate, you want to make sure that it's not over suppressing their osteoclastic activity. And so using BSAP is good for that. And the reason why is because so bone-specific alkaline phosphatase is produced during the mineralization phase of bone formation. P1NP is produced during the formation of the collagen. So two different timelines that BSAP and the P1NP are being activated. So we want to know when that mineralization is happening, when you're deciding whether a person is being oversuppressed by medication or not. So that's why I use BSAP in an oversuppression issue. So if this person's been on a bisphosphonate or Prolia for 2 or 3 years, yeah, you better see whether they're being overly suppressed by these drugs.
And if you're overly suppressed by the drugs, then that runs into another problem.
Well, you need a little bit of culling out of microfractures to maintain good bone quality. If you have zero osteoclastic activity, all that's happening is you're building up bone density because there's secondary calcification going on. It's not primary calcification, it's secondary calcium just kind of filtering in a little bit, increasing density. Does it increase quality? No, but it increases density. And so we just want to make sure that, some osteoclastic activity is going on to get rid of some of the microfractures that are going on. Over suppression, you're not getting rid of any of these fractures.
So we have the osteoblast cell, which is the builder, and the osteoclast, which is the cleans out. So just from a very brief little hint there, build is blast is build, C is clean away.
That's a good, I didn't think of that.
You can borrow that. You can flip me. And how about osteocalcin? Want to talk about that?
Oh my goodness, that is you know, when you talk about osteocalcin, you talk about how integrated bone is to the rest of the body.
Right.
And, you know, my new book is all about how bone is the center of your universe. And that is, it is the center of how your body works in total.
Mm-hmm.
For example, so osteocalcin is produced by the osteoblast and the osteocytes. So the osteocytes are the older osteoblasts that have embedded into the matrix of bone. And they the osteocytes, we haven't talked about that, but they essentially are they run bone remodeling. They are the ones that govern how the remodeling is going on. And they produce, the osteocytes and the osteoblasts produce osteocalcin. And osteocalcin, once it's become carboxylated or changed with vitamin K, it becomes a nucleator for the hydroxyapatite crystal.
So carboxylated is change. I mean, they're just bringing it down to simple terms.
Yeah.
So
it's changed so it can work in this manner, and that is to form the crystal of bone. It also instructs the bone formation process on how to align these crystals within bone.
Amazing.
So it's pretty important. And it's important that you have the vitamin K to make it so it can do these things. And then once the bone is made, yes, I think, you know, I can see in the look in your face how excited you get. And I get so excited about this too. I mean, this is
it's a miracle. It's a freaking miracle.
It is such a miracle that this happens. And we muck it up a lot of times with drugs. But it is a miracle. And so this carboxylated, vitamin K carboxylated osteocalcin gets embedded then within the bone that you make. And then 7 years later, when that bone is now remodeled again, the osteoclasts come and they break down that bone. They get rid of all the microfractures. And as they're breaking down the bone, and the acid that they put on that bone to break it down releases that osteocalcin, takes away that carboxylated form of the osteocalcin, makes it uncarboxylated. That uncarboxylated osteocalcin now goes to the brain. It helps the brain form serotonin for mood stabilization. It helps the brain make dopamine for pleasure. It helps the brain and the nerves in the brain produce neurotransmitters. It goes to the pancreas, helps the pancreas regulate energy for insulin production, for energy production. It goes to the intestines to regulate another hormone called glucagon-like peptide 1, which helps calm the intestines and make it so there's not so much peristalsis going on, so allows for more absorption of nutrients. It goes to the testicles and helps them produce testosterone. So, and all these are not huge amounts of input, but it is input to all these structures. And I think the way you have to look at osteocalcin and bone in general is that it makes sense that bone would regulate your energy production. Why? Because it is a huge amount of energy that it takes to feed these osteoclasts and osteoblasts to constantly just be turning over bone. You know, every 7 to 10 years, we have a whole new skeleton. That's a huge amount of energy that takes to make these cells, to allow these cells to do their job. So it makes sense that, and the skeleton itself is a storage place for calcium. It's a storage place for fat and energy. So when times are lean, there's no food around, then it's going to do one thing. It's going to kind of sequester things. So for the times when things are better, that, you know, you don't need to sequester it, but they are regulating your whole energy system. And it makes sense because they are a storage form, and they also regulate energy from fat, from pancreas, from everything else. So, and the osteocalcin is just a good way to understand that whole connection to energy regulation.
So one small question opened up that huge understanding about the importance of osteocalcin and how the mechanism works.
The importance of your bones and how that's important to the health of you in many, many ways. So if you have good bone health, you're going to have good other health too from the rest of your organs. Not always, but a lot of times.
So first, I just want to say hi to Tessa. Hi, Tessa, because she's from Australia. So when you say that the bones are made over every 7 to 10 years, I'm thinking to myself, okay, so I have osteoporosis, and in 7 years, I won't have it anymore. But that's not true.
No, because it's not just the bones that are being affected. You have to realize that what is an osteoclast? They're a form of a white blood cell. So they're part of your immune system. Your immune system was developed when you were 3 years old. So that's going to follow you along the way. So how your immune system works goes into the mix. So you can't just say, okay, I'm starting with a perfect body here at 43. I'm going to do everything I want. And in 7 years, Dr. McCormick says, I'm going to have a new skeleton. Everything's going to be okay. That's not true because we have history. And that history goes back to the first 3 years of our life when our immune system was being developed. And that immune system and how the bugs in our guts are, in our intestinal tract are, how the cells within the lining of our cells work and interact with the bacteria in our gut, and how all that regulates your immune system. And all those cytokines, all those different chemicals that the immune system uses to talk to each other, the T cells and the B cells, and just every single inflammatory or anti-inflammatory cytokine that's out there, all that noise, all that chemical talking that's going on, the osteoclasts are listening to it.
You know, I'm struck by, because I've been on some of the intakes with private sessions with my clients and you, and you'll be quick to come up with a scenario, well, at least what the bone markers that you want to have done. And what's behind that is what we're learning right now. It's like this massive amount of knowledge that says, you know what, let's do an osteocalcin, or you know what, let's do, right? But I just look at it as like checking the box. Okay, so that's what he wants, but now we're beginning to understand why you want it. So let's get into that for a second. So let's say a patient comes to you and they're sort of average, they're losing bones, they're a negative 3.5, let's say they're 65, and the health history is okay, you know, they're regular, they don't have any major problems. Maybe they have some gut issues, because everybody does. But how do you know? How do you know what to do? What do you do?
Because I've been doing it for 20 years. I don't know.
What is it, gut? Is it a gut feeling?
No. That's a good question. I mean, there's certain things I kind of do with everybody, but yeah, you ask some questions and it just fits in a certain way. If I'm thinking ahead, and I think ahead a lot of levels, and I think to the side a lot of levels, just kind of all at the same time. And if you're thinking ahead that there might be anabolic medication involved here that we're going to do, I'm going to get that P1NP. If not, I don't.
Okay.
If I'm thinking ahead that we're going to do a bisphosphonate, I might get that osteocalcin or bone-specific alkalinephosphatase, you know, to make sure we're not going to do an oversuppression later. But yes, there's a core amount of labs to get, and that's what you have on your list. That there's certain labs that are just kind of like, okay, this is basic. Let's get this on pretty much everybody. And then, yeah, you tailor, we might get a few more with people. Like if they're going to do Forteo, I might do an insulin-like growth factor 1 to make sure that they don't have a IGF-1 resistance, like you have insulin resistance. So I want to make sure that Forteo is going to work. So there's nuances, particulars that you want to do with certain people, but
yeah. But here's the thing. So you do all this focus, right? You're in the marrow of the bones, and you suggest, okay, from my experience of 20 years and writing 2 books, this is what I suggest you do. But you can't write the script for that, right? So
I can. I just can't go through insurance.
Well, you can write a script for the medication?
No. Just
No.
For the labs.
Right. And that's a really important point. And we could talk about that in a minute, but you can't write the script for the medication. No, so then the patient takes her chart and goes to an endocrinologist and says, wow, I don't think so. Then they have another level of discussion or argument. What do you do? What?
But the nice thing that I found about endocrinologists is, and I don't mean to say this mean-like, but a lot of times they don't know what's going on. They don't have an in-depth knowledge of osteoporosis. A lot of them. Some of them do, some of them don't. A lot of them are diabetes doctors, and so they don't have that much knowledge, and they'll essentially allow the customer, the patient, to dictate, especially if that person knows a little bit and knows when they go into the endocrinologist. Yep, I know a lot about bisphosphonates, Prolia. I know how much bone density they give me. I know that certain ones give me quality, certain ones don't. And just go in, armed with a little bit of knowledge, and then you can have a conversation with the MD and not just be told what to do,
And there's that fine line between showing up as a know-it-all and I'm going to show you, doctor, I don't care about your medical degree. You want a partner.
Yeah. I'm not saying to do that.
No, you're not saying that, I know.
We want this doctor to be on our side. We want them to be on our team. They're very, very valuable. They know a lot, but they just don't know a lot. Some of them just don't know about all the really little intricacies of these drugs and how they can be used.
And a rheumatologist versus an endocrinologist?
It matters. It's like when I go to a bone meeting of some kind, there's usually 90% endocrinologists and 10% rheumatologists. Okay. It just some doctors, emphasize osteoporosis, and some doctors emphasize, rheumatological diseases or diabetes.
Okay. So because this is about bone markers, let's talk about vitamin D. Did you read that vital study, or what's circling around as far as we don't need vitamin D anymore? You don't need to test it. Are you aware of that? No. Okay.
I mean, I do know that even though I like Dr. Hollick from Harvard, he has really taken this to a new level, and I do think that it was inflated a little bit in the importance. I think, yes, you need vitamin D. I certainly don't think you need more than 60 nanograms per ml. You should be between 40 and 60, but yeah, it's important. It does a lot of things. So for your immune system and for your bones.
So the vitamin D, we could talk about how, let's see. So you were talking about the facility that you use, or the lab that you use. It's called what? Dexa or something? Dexa? Where you can write scripts.
Oh, Vector.
A vector?
Evexia.
Evexia, okay.
I think that's what it is. I can't remember, but yeah, I think that's what it's called. Yeah.
Something like that, that you then can give patients who come to you a script so they can then take it to,
I just can't go through the insurance. Yeah.
right, they can't go through the insurance, but it's quite reasonable. I mean, vitamin D,
It's unbelievably reasonable.
unbelievably reasonable. I mean, the whole vitamin D conversation is mind-boggling to me because, you know, Quest, without a script, they were talking about $244. Life Extension is also another place you can get your own blood work done, and oftentimes they run sales. So Life Extension was doing it for $35. So it's like, well, that's quite a spread. Sorry, it's my old way of. Oh,
Whoa, where did Irma go?
sorry, the dog. So anyway, the point is that you suggest getting tested twice a year, right? At the end of the summer.
Vitamin D? For vitamin D, I just tell people to get it in, if they're in the Northern Hemisphere, to get it in February, March, April. So just once a year.
Just once. I do it twice.
Yeah. But to me, it's like that's the lowest point at you know, in the winter.
Yeah.
It's the end of winter. It's the lowest. So
I like to do it in the end of the summer because I want to see if I'm taking.
You're competitive, I can tell.
So here's what I want to say about that. That I like to track it because then I know, because during the winter I take 5,000. And then if I take 2,000 during the summer, maybe I need 1,000. So each 1,000 that you take, it takes a couple of weeks to change the vitamin D level, but each 1,000 adjust the number by 10 nanograms per milliliter.
And then some people need 5,000 in the winter. Some people need 1,000 in the winter. Some people need 7,000 in the winter. So
right, and it depends on the vitamin D receptors, right? I mean, whether or not somebody is able to take it through a capsule or they have to take it in liquid form. So there are different ways of looking at vitamin D measures. Yeah.
And I mean, now it's a lot better, but boy, 20 years ago, the testing was just terrible. I mean, you could not trust any vitamin D test, but now it's much better.
So it doesn't matter, Quest or LabCorp?
I don't think so.
All right. How about ionized calcium? Want to talk about that?
So calcium is bound by proteins and minerals in your blood. And then there's others that is free. It's not bound by anything. And so if you have, if your albumin's really high or low, it's going to affect your total serum calcium. Total serum calcium is that's bound by a protein, that's bound by minerals, and that's free. So sometimes total serum calcium, which is on your CMP or comprehensive metabolic profile, can be right on the borderline of, oh, it's a little too high, but it's not out of the range, especially when you're talking about primary hyperparathyroidism. Mm-hmm. So you want to know, like, the range for total serum calcium, the typical reference interval is, I think, 8.7 to 10.3 or 10.4. Mm-hmm. So if you're at 10.3 all the time and you don't have osteoporosis, then it's okay, probably. If you're 10.3 or 10.2 or 10.1 and you have osteoporosis, then it could be a problem. So we want to look at that closer. So it comes back at 10.1 and we don't know what's going on. We get an ionized calcium because that's not affected by these other things. And so that will give us a clearer reading of, is this abnormal or is it not abnormal? So mostly you use ionized calcium if you're trying to differentiate between a person that might have primary hyperparathyroidism or they don't.
And you use the standard blood work. You take a look at the CMBP and just track those things as well, because when you do an intake, you want to see all the blood work.
Yeah. CMP and CBC are great. I mean, they're dirt cheap and they tell you a lot.
They have a big story. Okay. Yeah. So that's important. And now celiac, it's important to test for celiac, and then you can go through all the IgGs and the IgA, but that's an important test unless you are off of gluten. Like if you're off of gluten, do you still test?
Sometimes when a person has some digestive issues and they have really bad bone loss, even though they're gluten-free, I'll test it anyhow, because as you know,
Oh, yeah.
sometimes a person can just go to dinner and they're so sensitive. You go out to dinner at a restaurant, even though they ordered gluten-free, but there's gluten contamination, and it'll set them off for a month. So it doesn't take much on some people. They're incredibly sensitive. So for those people, I might test.
Okay. And the CRP, you order the high sensitive CRP. Do you want to talk about that?
It's just, you know, C-reactive protein, you can get that, but if you really want to make sure that you're seeing it at all levels, even at the lowest level, then you get a high sensitive C-reactive protein. It's the same protein, it's just a much better assessment of it, because it's like the estradiol. I never get an estradiol, I get a sensitive estradiol.
Oh,
okay. Because an estradiol, when you order an estradiol, it's going to come back, it might say 25 or 30 or something, but also might say less than 20. But there's a lot of numbers between 0 and 20. And so I want to know what it is. I want to know if it's a 17 or a 7. And that's the sensitive or ultra sensitive estradiol. The same thing with high sensitive C-reactive protein. I want to know exactly what it is, and that'll give me a little bit better indication if I order the high sensitivity C-reactive protein versus the C-reactive protein. It's the same thing, just like the estrogen's the same thing. It just gives me a better reading.
So yes, that's very, very clear. Do you see any patients that don't have a gut issue?
Oh yeah.
Oh, okay. All right. So, and then of course you test for the thyroid. Yeah, always. Thyroid.
Yeah. So thyroid should be between, I'm sorry.
Go ahead. I got excited. Go ahead, thyroid.
Thyroid, TS, and I usually mostly just do TSH because I'm not a thyroid doctor, and I'm sure if I was working on somebody's thyroid, if I was really addressing a thyroid issue, then you'd get T3, T4, T3 uptake, you know, all that stuff.
The full panel.
Yeah, full panel, but I don't. That's not my game. So I just really want to know what the TSH is.
Okay.
If you're on a medication, thyroid medication, and it's a little too high and it's driving that TSH down below 0.5, then that can cause bone loss. If you have hypothyroidism and your TSH is up to 7 and 8 and 9 and 12, that can cause bone loss. So there's a sweet spot between 0.5 and 4.5 or so. So we want to try to keep somebody there.
All right, you want to talk about 24-hour urine and why is that important?
So all day long, you have X amount of calcium in your blood. We already just talked about total serum calcium, 8.7 to 10.3 or so. So there's calcium in there. And that calcium in your blood is being run through your kidneys 24/7, just all the time. There's blood going through your kidneys. And that blood is the kidneys pull out certain things. They put back certain things. So there's about 10,000 grams of 10,000 milligrams of calcium that run through those kidneys every day. That's a lot of calcium because the blood's just turning over. So, and it's putting back in most of that, but some of it takes out, about 200 milligrams, and you lose that in your urine. But sometimes there's problems with kidneys, and sometimes there's problems with your pH and the inflammation that's going on in your body that will, nutrients and things like that, that will cause the kidneys to lose a little bit more than they should. And so that's what you're testing in a 24-hour urine calcium. To just get a spot urine calcium isn't good enough. You have to pee in a bucket for 24 hours and have that analyzed.
And that's not as difficult as you think it is. I mean, I did that twice. And what I found the easiest thing to do is that I have a glass jar that's in a bucket of sort of ice to keep it chilled. And then I dump it into that orange thing because.
And you just put a yellow sticky on your forehead.
Yeah.
It says, don't pee in the toilet.
Right. Right.
Pee in the bucket.
Right. You have to pee all the time in the bucket. All right. So we have, this has been great. Thank you. Vicky, do you want to address any questions or present any questions? Because there seem to be a lot of comments. I can't hear you, Vic.
I unmuted myself.
Okay.
There were lots of questions, but I'm trying to keep it focused on bone markers. But
I know.
people did want to know about Echolite, if you could just what you think about it.
Well, I think before we go there, because that's a big one, was there anything else in here that?
Well, one question was, what about and when to do bone marker testing if no meds are involved?
Mhm.
Are there reasons to test bone marker with a low bone density but not diagnosed with osteoporosis?
Sure, because you want to know if you're losing bone rapidly and if what you're doing is working. I don't care if you're working completely with nutrition or working with a medication, you want to know if what you're doing is working.
Well said.
Okay. So another one, why do anabolics degrade forearm scores?
Oh, that's a good one.
You can't say anabolics degrade forearm score. You can say that the parathyroid analogs, Forteo and Timelos, not Prolia, which is kind of Prolia is really an anti-resorptive, but does have a little bit of bone quality to it. But then the other romosomazab, which is Evenity, that's an anabolic, at least for the first 9 months of use, and then it becomes an anti-resorptive. So it's kind of a dual medication. But the Forteo and Timelos, the reason why not always, they don't always, for sure, and most of the time they don't degrade it, is because they are parathyroid. So the reason why these two drugs work is because you inject a bolus of this parathyroid, this recombinant DNA parathyroid under your skin, 20 micrograms. It is there in your system for 45 minutes to an hour, and then it's gone. And so it stimulates the osteoblasts, and they build some bone. And then by the time the osteoclasts, because they're a little bit sleepier and a little bit dumber, by the time they smell that parathyroid in the blood, it's gone. Oh. And so they say, wow, I thought I smelled some parathormone there, which kind of excites me and makes me want to tear down bone, but now it's not there, so now I'm not going to tear down bone. So it stimulates the osteoclasts a little bit, but it really stimulates the osteoblasts much more. The problem is, if you are one of those people where it lasts in your blood a little bit too long, now it's going to stimulate those osteoclasts to break down the cortical bone. And we don't know who you are. And that's probably why Timelos might have a little bit more of a breakdown of the cortical bone than the Forteo, because it works a little bit better.
So I have one question that came in early. Excuse me, Vicky.
Okay.
On biotin, and this is from Jill. How long one should be off biotin before they take bone marker tests?
The literature says 12 hours. I say 48 just to be sure. The literature says 10 milligrams. I say 3 milligrams because I know I have a product called OsteoStim, and in that I have 3 milligrams, and I know that affects people because people have forgotten and taken it, and then then it affects the bone resorption markers. And so I go, oh, that's a little weird. So let's retest it, and they stop at 3 milligrams, and it's different.
So the point is that if you're doing any of the tests, you have to look at the supplements that you're taking.
Yeah, don't just say, and probably that's my fault that I just say to people, no biotin, no collagen. I don't say, look at all your supplements because it might have biotin in it,
It sneaks in. And then the Timelos, this same person, Jill, went from Timelos to Reclast, and the bone markers went down a lot. And the doctor says that that's normal.
Yep, that's where it should happen. Yeah.
So the bone markers,
you want those bone markers to go down because that's what the reclass is doing. The Forteo or Timelos increase both P1NP and the CTX or the NDX, whatever. And now the reclass is going to come and squash that down and decrease that osteoclastic activity. And as you decrease osteoclastic activity, osteoblastic activity naturally comes down with it because these two types of bone cells talk to each other.
Okay. So we only have a couple of minutes. Do you have any interest in staying a little bit longer after I stop the recording, or do you have to go, Dr. McCormick?
Okay.
You're okay. So Vicki,
People want to know the name of your book and when it'll be out.
yeah, let's talk about that.
It's called Better Bones. And I'm hoping maybe by end of September, October, something like that, but I don't know. And it's long and tedious, and there's a lot of information, and it'll be a little too much for some people, but I want it to be in depth, and it's going to take people to a new level of understanding.
And that's important. I mean, that's why these webinars are so important, because you get the language down, you get the terminology, it starts rolling off your tongue a little bit easier. You could talk to your doctor about these things. The first time it was like, Greek, but now it's like, okay, I could actually talk about osteocalcin, or I could talk about a CTX. So yeah, it may be that, and it may be that people just take it in their own bite-sized piece and go through it.
Unfortunately, osteoporosis, you really do need to pay attention to this and really do need to understand it, because unfortunately, a lot of doctors don't take it that seriously, and they should. And they're not going to give you the time of day. They're not going to go into this in depth with you. So it is a lot of time, but in this new book, I give it to you. It's like, okay, this is a lot of years of figuring all this out, and it's all in one place, and you don't have to go everywhere to figure this out. It's there, and I try to explain it as simply as I can, even though it's really complex, and it will benefit you in the long run, because you don't want to have fractures. It does really crimp your lifestyle. It does really, it's not just pain of having a broken bone, it decreases your function.
So one quick question, maybe two. How does collagen affect the CTX?
Good question. It probably, I'm not sure. I mean, it might actually even increase it, because it's stimulating your osteoblasts. So, you think of it as, yeah, it's going to increase P1NP. It might even increase CTX, but not a lot. But it's just improving your bone formation. And so I wouldn't use it to bring down CTX.
Okay. Dr. Iris, yes, there will be a replay, and the replay will be available until the 26th of August. You'll be getting it as soon as I can upload it. What is Irma's website? My website is Food for Healthy Bones. I'll write that. Vicki, could you put that in the chat?
Yes.
Oh, then there was did you have another question, Vicki, or other questions?
Well, there's a few more have just been coming in.
Okay, so why don't we bring this to a close, right? And then those that want to stay on can. And we could talk about Echolite, and we could talk about other things. So Food for Healthy Bones is my website, or if you type in my name, irmajennings.com, that brings you to Food for Healthy Bones. There is one thing in closing that I want to say. When I listen to Dr. McCormick talk about the nuances of bones and what it takes and all the building, when I think about whole foods, I think that there's such an important relationship, because when we think about bones, we often think about collagen. But bones need 20 vitamins, minerals, protein, and fats to support bone growth. And that's why it's important to look at the food that you're eating, organic as often as possible, rotating your food, not just mono eating like the monocrops that we grow in this country, just to rotate your food and to have a really good wholesome diet. So I'm going to end on that note. And so if you can stay, Dr. McCormick, and if anybody has to leave, thank you for your time, and you'll get the recording. So I'll stop the recording.